Hi everyone, this is Bill Riley with Medical Advantage Group, and on behalf of all of us here today, we'd like to welcome you to our webinar, Getting More Out of Your EHR in 2018. Before I introduce our speakers, I want to cover a couple of housekeeping things. First is we've got a good number of people on the line here today, so we're going to keep the phone lines muted during the broadcast. We will be pausing for questions towards the end. So please use the little question text box on your GoToWebinar control panel. Submit any questions that you think of as we go, and we'll take those towards the end. Let's see, as always, we can see a number of you have joined us with webinars here in the past. I'll just reiterate, as we always do, at the end of our session, all registrants will get a copy of the presentation materials as well as a link to the recording of our session. Let me take a minute and introduce our distinguished panel of speakers here today. First, we have Chad Anglin. He's our Director of In-Practice Technology Services at Medical Advantage Group. He leads the team, our EHR team, which I think to date has well over 1,000 EHR implementations, go-lives for providers. Well over 10 years of experience with EHR strategy, implementation, optimizations, regular speaker at industry conferences and events on a range of topics. He's also a very active contributor on social media. So if you're not already, I would encourage you to like, follow Chad, approaching celebrity status quickly. All kidding aside, really a strong mix of understanding the gory details of EHR technology as well as an appreciation for how practices operate. We also have Angie Howard. Angie's a senior consultant on Chad's team. She's the one going into practices, working with directly with physicians and office managers and practice staff, just helping people get the most out of their EHR. Angie, I think you yourself have directly helped hundreds of practices launch and optimize EHR systems. Prior to joining us here at Medical Advantage, Angie was sort of the customer herself, working with a couple of major health systems in and around Metro Detroit, Beaumont, Ascension, and most recently Henry Ford. Angie has EHR certifications in both eClinicalWorks and Epic. And finally, we have Candace Lewis. Candace is our Director of Revenue Cycle Management Services, helping practices with billing and revenue cycle, cash flow issues for over 15 years. In addition to working at Medical Advantage, has also served as an adjunct professor at Davenport University. For those of you familiar with the Grand Rapids, Michigan area, teaching EHR, practice management, insurance billing, and coding. So welcome to you all. Let me hit on our agenda for today. We're going to be talking about EHR and really use this as an opportunity to get the most out of your EHR in 2018. We're still very early in the year, early in the month of February, lots of runways still ahead of us, so this is an opportunity from an EHR perspective, a billing perspective, to get started, get the year started on the right foot and get the most out of our systems. So let me just talk about our topics. We'll talk a little bit about physician and staff burnout as it relates to EHR. Chad's going to take us through some opportunities to improve productivity and I think reduce some of the burnout and frustration often associated with an EHR. Angie will talk a bit about macro. We're in year 2 of the macro program, so some things to be thinking about. And then Candace, Angie will talk about some things related to billing and revenue cycle management. So first, let's take a look at this idea of physician and staff burnout. This is what providers are saying. I don't think this is new news to anyone. This is a topic that gets written about a lot without really trying that hard. We found all kinds of social media posts and updates. These are from actual physicians, and this is what they're saying. You know, the fact that physician burnout is an actual hashtag is interesting to us. You know, clearly these kinds of things, you know, unintended negative consequences about moving from paper to electronic health records, of course, that's an issue. James Hebel is saying this is really time to think out of the box. You know, EHR is not the only factor here, right? There are other factors, but clearly the EHR system is a contributing factor. Another thing to talk about here is just the bedside manner of clinicians today, that often office staff, they just have to be so focused on updating the note correctly. Many times they're spending more time looking at the screen or looking at their tablet, updating the note or what have you, than looking at the patient. Perhaps it's an EHR training issue, right? I had Epic at my last place and it's all scripts here and I'm not really familiar. You know, maybe it's a broader sensitivity kind of issue, but the EHR certainly contributes to this problem. Another is just speed and how long it takes to use many of today's EHR systems. I think all of us are consumers of technology ourselves. If you think about it, right, I can click a button and in 2 days, the Amazon thing, right, I want a Phillips screwdriver, a coffee mug, and a set of snow tires, and like magic, in 2 days it's sitting on my porch, right? Or I want to take a picture of that personal check and have it deposited into my account, right? Yet here's this cartoon or this update where I just want to print. I hit a button and print to the printer 4 feet away from the workstation in the exam room. Why doesn't it work? Or you know, the cartoon is about, oh, this is a billing sheet, and gee, could you, the patient, fill it out for me? So I'm sure we can all relate to these things. Chad, with that as kind of a backdrop, I think this leads us into some of the issues associated with EHR in terms of improving productivity, but also, you know, hopefully reducing some of the frustrations that people see. So I know one thing that you like to talk about is just in many of the systems you and Angie see, or many of the practices, you just get a ton of EHR screens, and I think users can struggle with just the overload of so many screens. So what are some ideas maybe to overcome that?
No, I think that's a good one, Bill. You know, very commonly, you know, as the team's out with practices across the nation in a variety of different EHRs, especially those practices moving from implementation and kind of letting the dust settle on that and moving into optimization. You know, for years it's been requesting more information, which is obviously a main goal of the EHR, but I think it's really caused almost like cognitive overload in what you're looking at. So the more information put on a single page or within a window obviously gives you access to more information, but if it's not information that you need personally as a user, it can really overload you and almost get in the way. And you know, what we try to look at is looking at how your settings personally as a user are set up in the system. And I know a great example, eClinicalWorks has what they call the My Settings, or miscellaneous configuration option by user. Which is really a great feature because it eliminates a lot of the overload of information that you as a user may not need. And examples of that may be alerts, you know, for your specialty or really your role in the practice. If it's not something that you know, you need as a user, then you don't want to see it. I know that's a big complaint when I work with all different staff members within a practice, is if I have to scroll through or look around or really hunt and peck for the information I'm looking for, I'm doing my patient a disservice. I'm not listening to them. A very common, you know, I guess, issue that leads to physician burnout and staff burnout is, you know, you're just trying to get the information that you used to have right in front of you. So properly setting up alerts and clinical decision support and, you know, your progress note, your templates, your order sets to meet the requirements of you as a practitioner and not the system, which may be meant for general practitioners, specialists, care managers, really looking into that. So, and then taking that perfect setup and perfecting the workflow. So mapping out that proper workflow and putting into practice. So really each user becomes more efficient, not just focusing on the physician, but looking at the care team, looking at the nurses, the medical assistants, the billers, all the way through the EHR.
Okay, very good. Another idea is around care coordination. How can someone listening today use care coordination strategies to better manage the population, once they walk out the door?
And Bill, I think that's another great one because, as again, practices are moving on from just getting implemented and getting through the day, they're feeling like care coordination strategies have just been left out. We were trained on how to document in our EHR when the patient's there in front of us, but really how to better manage that patient population as they walk out the door. So, that could be looking at tests that were ordered, maybe following up on those, closing the loops on referrals to specialists, PCMH and meaningful use, and a variety of multiple rounds of these incentive programs have helped with that, and a lot of the EHR technologies have the tools. But again, putting that in place in your practice, working on the workflows, how do I find out what's due for my patient population? How do I keep in touch? What technology does my vendor, really partner with your vendor, partner with your optimization team to see what's available out there that can increase the communication with your patients, as well as maybe lower the amount of time your staff is spending manually tracking. I still go into practices today where they might have that file cabinet for recalls that they've used for the past 25 years, when in all reality, the technology's there in their EHR to run a registry report on open items, from appointments that are due for physicals to orders to referrals, as we mentioned earlier. So, I think there's an illusion that just because the EHR is certified, everything is done for me and I'm using it as designed. But I can guarantee you a practice, whether they've had an EHR for 6 months, 12 months, 24 months, 5 years, there are new features coming out every single day that could, better streamline your workflows in the way you use your EHR. So.
Okay, very good. So next, this is a cartoon with a person literally drowning in data, being swamped in data from a variety of sources. I think is another common issue that I don't think is going to end anytime soon. So how can a clinic or a practice better measure the constant inflow of data?
Right, Bill, and again, another great one, because almost every single practice we talk to today, the physicians are staying later to just try to absorb some of the data that's coming into the practices that have never come in before, whether it's faxes or some of the new HIEs that are electronically integrated, or lab and radiology results, or summary of care records, which came into play with meaningful use, and now MIPS, where providers are tasked with sharing quite a bit more information as they move patients to specialists. And of course, if that information is coming in to your EHR, you need to make sure that you're taking action on it if it does, stand out to you as important to that patient. So, that's probably the largest complaint right now from, my physicians that we work with is, I just can't handle all the information. I'm staying till 7, 8 o'clock at night. I'm getting home, spending very little time with my family, and then again, going through just hundreds of faxes and information that's really not as actionable as it could be if it was electronic. So, I think data gaps are wide, and providing care across the continuum really becomes a grueling task with a lot of these EHRs, which are very fragmented. Even though they may have the technology, practices just aren't aware what's available to them to help. So really, sitting down, again, partnering with your EHR vendor or reseller or optimization team, looking into things like Care Quality and Commonwealth, where you're able to send, share, receive electronic information that's actionable instead of just a fax that either sits on a fax machine and requires staff to scan it in and then assign it to you, and then maybe you have to sign it and print it out and do something with it. But switch out of that standalone fax machine. There's so many digital options available today. Meet with local lab and radiology facilities. I still, I'm so surprised today on how many of our practices are not connected with local vendors. I mean, looking into what your physician organization has available or local health systems have for connections. Local HIEs, there's some great HIEs across this country which have partnered with all the major EHR vendors to share data across the continuum of care. Engage other local practices that you refer to or receive referrals from to share electronically. There's so much technology when it comes to that, with like eClinicalWorks, for example, has P2P, and like I said, some of the other Care Quality and Commonwealth. Get these practices, get these physicians on board to engage in the electronic sharing of data. It helps everyone. It helps close loops on open orders. It helps with communication and accepting data. Really, all in all, saving time. And I think that's one of the major reasons for burnout is just the big influx of data now available to these physicians.
Okay, great. Thanks a lot. There's already been a couple of questions coming in on some of the things you just covered, so we'll get back to those in just a minute. I'd like to shift gears now and maybe give Angie the opportunity to talk a little bit about, we're in year 2 of MACRA now, and some things we should be thinking about as we look at 2018.
Thanks, Bill. Yeah, so the idea of MACRA was to combine the 3 programs into one. And when it first started and we were looking into it, we were looking at the proposed rule and then the final rule, we found that this looks great. They're combining all the programs into one program. This is going to be easy for the practices. Well, what was talked about was totally different when it was put into practice, and it became extremely confusing. I know for our clients, the experience of the first year MACRA was frustrating. They weren't sure on which measures to choose. The measures didn't make sense to them. The scoring didn't make sense. In some cases, you had to be a mathematical genius to understand how you could achieve the scores. And then it came into place, how are you going to report? Will it be a registry? Will it be claims? Will it be your EHR? And the measures you chose, do they fall into those categories? So it was very frustrating, and it still is frustrating for our clients. A lot of the doctors and practices feel like just when they get the hang of something, when they got the hang of PQRS, when they got the hang of meaningful use, the government changed it. And they feel like that with their software too. As soon as they get the hang of something, maybe their software is no longer certified and they have to move over to another EHR. So it's supposed to make their lives easier, but as we've heard in our practices, it doesn't. So looking at year 2, the difference, there are many differences, but I think the main difference for private practices and physicians is cost. So cost is going to be added into the equation for year 2. And we knew it was coming. It was not scored for year 1, but it is scored for year 2. So aside from the clicking of the boxes to keep up with quality and to keep up with ACI, now they have to think about how much are their patients costing CMS. So this isn't a measure that the practices will attest to. It will be scored based on their claims. So when practices come to us, they say, well, what can we do? They're already overwhelmed with payer programs, so what can they do? So the first thing I tell them is you have to understand the program, which means that the doctor has to assign somebody in their practice to be that SME, that subject matter expert. And the provider themselves they need to understand the program. So once they're choosing their quality measures, they need to understand why they chose those measures and how it pertains to their day-to-day documentation. So once you understand your measures, you've chosen your measures, how are you going to report them? Because not all measures are supported by EHR vendors. So you need to be sure that if you're choosing to report through your EHR or through a registry, that those are supported measures that you're choosing. Once you've elected someone in your practice, maybe elect more than one person depending on the size of your practice, be sure that that person is attending CMS webinars. CMS has a lot of free webinars that happen often. They record their webinars so you can listen and watch at any time. And you need to work with your vendor or get a support person or hire a support company to help you choose your measures, where to document. Work with your vendor to be sure that they have a dashboard. You should be able to look at any given time at your real data in a dashboard view to know how your providers are doing. Because this year, another change, cost and quality are scored for the entire year, meaning there's no room in June to decide you're going to jump on the bandwagon. So 2017 was the trial year, 2018 is real. So you will feel the effects in reimbursement if you're not on board immediately. So most likely the vendors will have webinars. You can hire project managers within the EHR vendor company at times. And there are many resources out there. There are companies like MAG that support practices. We have macro experts on our team that work with practices all day, every day. That's all they do. They're in practices, they're on calls with them, helping them if they're changing the measures they've chosen or trying to understand what they need to do for ACI or improvement activities. They have that support within their practice and outside of their practice. So if I was going to give advice, the best advice I can give is get somebody within your practice to understand the program and reach out for help if you don't have that person or you don't understand yourself.
Okay, excellent. Next, we're going to touch base a bit on fee schedule updates.
So with the new year comes new CPT codes, new payer updates, and additions to the payer fee schedules. So as a result of this, it is highly recommended that practices complete an analysis of their fee schedule to ensure revenue optimization. So for an example, if a practice charges $100 for a procedure and the insurance fee schedule for that same procedure is $200, the insurance company is only going to pay you that $100 that you've asked to be paid. So this can result in a monetary loss each time that procedure is performed. A fee schedule analysis can be completed by obtaining your practice's fee schedule, the fee schedule of your top payers, and then once you've reviewed those to determine if you need to update your practice fee schedules, you need to make sure that you're updating that within your system as well so that those new fees can be calculated as claims are being sent to the insurance company.
All right, thank you, Candace. Continuing on, we have other updates around the Medicare program, Targeted Probe and Educate.
So Targeted Probe and Educate, which is also known as TPE, is a new initiative for the Medicare administrative contractors, which are known as the MACs. So this new initiative is to review clinical documentation and prevent improper payments. The focus of the program is to limit the number of medical records requested for review and really put emphasis on education and assistance in obtaining corrected claims and making sure that you have limited claim errors. So the goal of the program is for them to help the practices with those issues. Not all providers are going to be approved as a TPE, so the MACs are actually using data analysis to identify providers that have high claim errors or unusual billing practices. So some of the errors that the program is focusing on are the signatures of certifying physicians not being included. If there's encounters that don't support the documentation, you always want to make sure that your documentation supports medical necessity. So their focus is on those few errors. How the program works is by the MAC selecting the practices. If your practice is selected, you will receive a letter from the MAC notifying you that your practice is being selected as part of the TPE. At that point, the MAC will review 20 to 40 of your claims, and they're also going to look at the supporting documentation. If your medical records support what was billed, you will not be reviewed again for at least 1 year based on the data service that was audited. So if the documentation does not support what is being billed, then the physician is going to be invited to a one-on-one education session. After that session, the physician will be given 45 days to make changes or any improvements, and then another review will actually be performed. So once the re-audit occurs, providers that do not have improvement after 3 rounds are then going to be referred to CMS for what they're calling next steps. And those next steps could include 100% prepay review or other action. Having to be involved in a prepay audit can, that's a significant financial risk to your practice. So based on this new initiative, we definitely would recommend that practices have an audit performed to determine their risk level. Looking at your documentation, looking at the information that's being submitted to the insurance company, and really making sure that if you're billing out a 99214 office visit, does the documentation support that? And if not, then reviewing with a provider what needs to be done to ensure that proper documentation is being supported.
Okay, this program is live now,
Yes,
right?
it is.
So, okay, very good. Thank you, Candace. Okay, so we're going to stop next and take some questions. We've had a number of questions come in. I'll remind everyone again, if you've got a question you'd like to submit, please just use the little text window in the GoToWebinar panel. I think what we'll do, we've had some EHR-related questions come in, as well as some MIPS or macro questions, so we'll kind of group them together. First, Chad and Angie, just relates to training. We've had turnover since we've implemented our EHR. How do you recommend relaunching or retraining people so that we're using it correctly?
Excuse me, I think that's a great question, Bill. Just like, we see it over and over where there's maybe management turnover in a practice or physician turnover in a practice. There may also be staff turnover in the same practice. So really looking at ensuring that you've given your staff and empowered your staff with all the tools that they need. I know we offer a service for practices that are onboarding new employees where we can come in and do really an updated training based on the role of that employee, but really ensuring that your entire practice understands the basics of the EHR, as it really is the central tool in your practice. Next, going and understanding the programs that you're in as a practice. So you really can't be successful in a program unless you've absorbed those that you're in. So all the metrics, what you're really trying to accomplish as a team. And that can't be something that's just shared between the practice manager and the physician. It really needs to be something that your entire team has bought into, whether you're a practice with 1 provider or 100. Or even beyond. I know we have practices joining us today from all across the United States with a variety of EHRs, a variety of specialties. So really looking at, what you're involved in as a practice as we switch to this value-based model, that's how you're going to get paid now. And all the team members need to understand that it's not just about getting patients through anymore. And getting, when I first started implementing EHRs about 12 years ago, it was getting back to the patient load that I had before. And now really it's about keeping your patients healthy so that you can earn more incentive dollars. Beyond empowering your staff with training, really assigning roles to those staff members. So it no longer can just be put on the practice manager's shoulder or a lead physician's shoulder anymore. It really you need to have SMEs, as Angie mentioned, in different areas. You may have a macro MIPS expert. You may have a staff member that really takes on the role of understanding your commercial programs. You may have a staff member that really looks at how efficient your practice is and really what you're trying to get out of, these optimization efforts. Every one of you that joined today are trying to become more efficient. Is that eliminating clicks? Is that outperforming your benchmarks and those value-based contracts, or really just trying to get home to see your family by a decent time? And lastly, engaging with an optimization team to bring in a viewpoint from outside of your practice. A lot of times I see, even with these very large practices that have certified EHR experts on staff, they've really just seen what's in that practice or maybe brought from one other practice previously. But meeting with your vendor regularly, meeting with an optimization team that's seen thousands of different practices very regularly, and looking into not only efficiency efforts and what you already have, but looking at add-ons. I think a lot of practices, given that, money is so tight right now, thinking about even adding something that's considered an add-on and maybe an expense is very difficult to do. But a lot of times, something as simple as, a text messaging feature may seem, hey, I don't really want to pay 5 or 10 cents per text message. But looking at the time it would take a staff member to go through and run reports on open gaps and then calling each one of those patients, 5 to 10 cents per message is nothing in the big scheme of things. So you really need to look into that. And then the last thing I'll say is run reports on everything. Run billing reports and revenue reports, run reports on your incentive programs. Look and find your gaps. That's your money. Not only for scheduling visits and appointments and tests, but also when it comes to your value-based care, everything's related to gaps in care. So run those reports, find reports that are available in your EHR, and work with your EHR vendor to see what else you can run reports on to become more efficient.
Okay, excellent. A follow-on question, where do you typically find the greatest inefficiencies in clinical workflow?
Over documentation.
Over-documentation.
Yeah, I think providers overcompensate because they're not sure. So a simple cough visit could be 3 pages long.
Yeah.
So they just don't know where to document, so they just document in every section of the SOAP note.
Yeah, I think even to add on to that, that's exactly what I would say, Angie, too, is that providers are so worried about risk. Did I document? And then beyond that, now there's these new value-based contracts where you need to document very specific things. And if you aren't sure where to document them, I'm seeing providers now that are documenting the same thing in HPI, ROS, and examination just to ensure, I put it in 3 different structured data fields. It's got to report from there. And I think, as Angie mentioned as well, we're seeing providers that are being forced to document in 2 or 3 different places because there's 2 or 3 different programs that they're in. When in all reality, maybe if you would have brought in, your EHR vendor, or maybe even your, data warehouse provider or team, and looked at, can we find a common spot that can be properly mapped to report for all of our different incentive programs that this specific measure relates to. So I think that's right on.
All right, thanks. There are a couple of macro questions. Let me kind of lump them together. They're just around, what's the easiest way to report? And I think a related question is, can we set up templates to fulfill NIPS obligations? Can you guys take that?
So the easiest way to report depends on your practice. A lot of practices find claims-based reporting for quality to be easy. However, if the biller is not entering in the proper codes, then you're not getting credit for the work you're doing. So I would say claims is the most popular next to registry. The great thing about some of the EHR vendors nowadays, like eClinicalWorks, is they are a certified registry. So you're documenting in your EHR, and they're able to pull that data for you and report it. You just need to be aware of what you're documenting. So kind of like what Chad said, you have to make sure that you're documenting in the correct place, because you could be doing the work, but you're not documenting it correctly. So I would say claims and registry are the easiest ways. If you don't feel like you have the relationship, I know some of the hospital systems, it's more difficult to control where documentation is placed. So those folks usually choose claims-based reporting.
Okay, great.
And templates, you asked about templates. Yes, you can set templates up to capture structured data.
Okay, very good, very good. All right, that wraps up our questions. Let me just do a brief commercial for the EHR and revenue cycle services available from Medical Advantage Group. From our fine panelists here today, from Chad and Angie's perspective, it's really everything around this wheel, from helping you with EHR strategy to select the proper tool for your environment, to helping you launch and go live with your staff. optimizing the platform, calling out some of the things like care coordination and referrals and campaign capabilities out of the tool that Chad mentioned. These are all things that we can certainly help with. From a revenue cycle management and billing perspective, Candace and her team is available to help with the billing operation within your practice. We routinely find practices that just the biller is stretched way too thin or stretched in too many different directions, and the claims start to suffer. So Candace and team is available to help take that on, work with the insurance company, resolve any claim issues, get your accounts receivable moving in the right direction along with your practice cash flow. More information is available at our website, medicaladvantagegroup.com/EHR services. We've just recently updated some overview videos. We've got client testimonials as well as a deeper dive into the services that we provide. So please stop by and check that out. If you're interested in learning some more, or you'd like maybe to set up some time to speak with Angie or Candace or Chad, Bailey Sutherland is our superstar point of contact. So Bailey's information is available there. Please feel free to contact her. And that pretty much wraps things up for today. As I mentioned at the beginning, we'll be following up shortly with the copy of the materials and the recording, so you can be on the lookout for that. On behalf of our speakers, Chad, Angie, Candace, myself, thank you all for joining us. We see a number of familiar names, but also some new ones. So I know we're all very busy. Thank you for taking some time to join us today. I hope the session was useful. We will look forward to seeing you again on a future broadcast, and please enjoy the rest of your day. Thank you.